have our update from Beacon Hill here. One of our esteemed visitors that we see everywhere in Milford all the time. Dick, why don't you say hello?
How you doing?
We're fortunate that the good senator does come on regularly to give us an update. I was going to say, the first thing we always think about is how long you've been working on healthcare reform.
Well, it seems like it's constantly being reformed and sometimes constantly needing reform. Healthcare is just such a dynamic profession. The sciences are changing, the needs of the patients as the society gets a little older and has more health needs changes. So there's a lot going on. There are a lot of new discoveries. We're seeing now, and there's actually a company in Milford, Avisha, that deals with something called oligonucleotides, which really means getting in and being, if you have a predisposition to have a certain genetic illness, going and changing the cell structure so you don't get it. And more, I know that Dr. Mello, who won the Nobel Prize back in, I think, '07 in medicine, what he's doing all the time up at UMass in Worcester is this sort of thing of dealing with genetic makeup and what can be done. So design, in effect, to design our medication or design our treatments that will eliminate the need for surgery or for other kinds of treatment down the line. And it's the next 5 to 10 years, I think, will be amazing in the discoveries. As a result, policy has to catch up. As the science or the profession moves ahead, we need to catch up. And we've been, the bill that we're taking up this month is dealing primarily with how do we get costs under control without hurting access to care or the quality of care. In fact, we want to improve the quality of care. The first bill that we passed, the reform bill, and Senate President Murray and I she wasn't president at the time, we were on the conference committee and designed it, was our bill that now has kind of set the tone for, I guess, for the national model, for better or worse. And the primary role of that was to expand access to care. We were in pretty good shape with the number of uninsured compared to the rest of the country, but still too many. Probably about 450,000 people at the time, so 7% or so of the population. We're down now to less than 2% that are uninsured. And what we also started, and it doesn't get talked about very much, but it wasn't just access that we were dealing with at the time. We also wanted to make sure that we did things to try to begin to deal with the rising cost of care, and that's a slower process. It's comparatively easy to sign people up for insurance and figure out what they need as a subsidy to afford it if they need one. But it's a lot more complicated to change habits and patterns of procedures and things, the training that people have had. So but we did. We started seriously investing in health information technology, medical records, electronic prescribing, things that would reduce mistakes or errors and spot potential mistakes, like a mixing of certain drugs that shouldn't mix, and looking at the testing and getting results quicker, having less reliance on paper for the doctor to be able to look at the computer and know more about what the tests that you've taken mean than to try to sort through a whole stack of papers. And we did that, and we also began then a statewide infection prevention program. Unfortunately, it's still, people still get sick when they go into a hospital because they're at a reduced resistance level, and somebody comes in, and it can sometimes be the doctor, who transmits some bacteria that you're not used to, and causes serious
Well, no matter
infection.
what, any opportunistic virus or bacteria
Sure.
is going to have a better chance of infection when you have people with suppressed immune systems.
Yeah. And that's part of it. And we've made progress. We're not still where I think we need to be, and where a lot of people think we need to be. But we're probably better than the rest of the country. But the rest of the country's not that great. So it still means we've got some work to do. And the hospitals are doing a pretty good job of trying to get that under control. Then in 2008, we had another major reform, some tweaking of what we had done in 2006 to make sure it would keep working right, but also focusing again on quality and cost. Went even further on health information technology in that one and created what's called the State eHealth Institute, which is in charge of setting a plan of how do we roll technology out across the state, ultimately getting everybody with an electronic patient record, hopefully one that they can have individual access to at some point so they can help manage their own health care as well and follow the procedures, know what they're supposed to be doing and get reminded about it. And also have the ability to call up a test that you might have had and make sure it's of an equal quality so you don't have to have the test taken again, which only adds to the cost and sometimes poses some risk to the patient. So we did things like that and more monitoring, more transparency, and we also gave the Attorney General the ability to really look at what's going on with the contracting between insurers and providers. The different health plans like Blue Cross and Harvard Pilgrim and Fallon and Tufts, when they sit down and contract with like Milford Hospital or a doctor's practice, the Tri-County Medical Associates or whatever, that whatever they agree to ultimately then gets reflected back in premiums that we end up paying. So if they can agree to a price that doesn't raise the premium so much and performance that is good quality so that you don't get sicker from treatment, then that helps us. And then in 2010, the third phase of health reform was to really focus on small business. We created a limited network for small business. We allowed a couple of organizations, the Retailers of Massachusetts and the Association of Chamber of Commerce Executives, to group together to hopefully offer a more affordable insurance product for their members and their employees. And that included at the time a 5% state tax credit that would match along with what is now available, the 15% federal tax credit for the cost of the policy for the business. So this time, the bill that we're now doing, which is deals with quality and finance of healthcare, we do several things. The major thing, and this is something no state has done yet, so again, we're being watched by the federal government and by other states. We set a cost goal. Right now, for instance, premiums on average have been going up about 6%. Now, some people have gotten double digits, that varies, but across the whole system, all the different types of insurance and the different sizes of the market, it's around 6%, 6.8 I think it is actually. The economy, the state's economy, is about 3.1. So we want to get the growth in the health costs closer, ultimately at least, whatever the state's, it's basically the growth of the state plus inflation together is what we call gross state product. And so we want to get it to that level. So the bill says that we will, starting right away, we will want providers collectively, and individually they've got to kind of be in that ballpark, not to have overall the right numbers, to get to gross state product plus 0.5%, so at about 4%. That, if we can do that, and they need to do that for 3 years, and then after that they've got to get to actually gross state product. And so in 15 years, the economists tell us if we can get them down there, that will save over that 15 years $150 billion. Now what that means to the average family, each worker would actually put about $5,800 in their pocket on an annual basis. The businesses collectively would save about $21 billion that they now would have to invest either back in business or hire more employees or whatever.
Or survive.
Or survive. And so there's some real benefits to that, but do it while you're improving quality and not cutting anybody out of the picture. So we do a lot of things to make that possible. First, we create an authority, a quasi-public authority, because we wanted to take it out of state government so that it's not at least quite as subject to the political will and whims of whoever's the governor. And to have them be able to say, this is, okay, the legislature set this goal, we're going to monitor this and make sure that everybody gets to it. If there are providers or payers, the insurance companies, that they're are not contributing to that goal, we're going to ask them to come in with a plan of how you're going to get in line. We're not, the version we have, which is different than what the House has been talking about, is less regulatory. We want the market to react positively to what we are trying to do. By doing that, they can look, the authority will have annual hearings, they'll bring in experts, and if somebody's not performing, they say, well, show us a plan that they plan, and if it works, then fine. If it doesn't, then they come in with another plan to make it work, and if they don't cooperate, there's a potential financial fine that the authority can impose. In addition, we take what is now one state agency, which is under the control of the administration, whoever it happens to be, a governor at the time. It's called the Division of Finance, Healthcare Finance and Policy. And we create that as something like, similar to the way the Inspector General's office is created. We take it out of the bureaucracy. We want to keep it doing what it's doing of collecting data and actually make it be able to do better. So we really have the information we need to make good decisions. And we create the director, just like the Inspector General is appointed by the governor, the Attorney General, and the auditor collectively. 2 out of the 3 have to agree. And they have 5-year terms, so they can't be replaced unless they do something illegal or whatever. So it's got some independence, and we think that will actually help hospitals and insurance companies and patients to have some greater credibility in what the data is that's being proposed. It's not being manipulated to fit the policy needs of the governor at the time he's facing re-election or whatever. And there's always the suspicion.
Well, a 5-year term could outlast the normal governor.
Sure, yeah. So it gives them some independence and security, but and you pick the right professional. We also move from, right now, the way doctors and hospitals are paid is each thing that's done is a fee to it, so a fee for service, it's called. That can be, the way it's done can be wasteful, and it's hard to track. So what we want to move more and more people to is we'll pay so much money each year to keep Correia healthy. And
so it's a performance rating.
Right. And so we'll start by getting Medicaid, the public health program, Commonwealth Care, which is the next above Medicaid for the folks that don't qualify for Medicaid, but it's subsidized by our insurance companies, and the Group Insurance Commission, which is the state employees and many of the town employees now, their programs. They will be the first that we want the state to show leadership to the private side. Now, some of the private side, Blue Cross and Harvard Pilgrim to some degree, they're working with partners and with other groups to have what they call a quality contract. They'll say they can, for this amount of money, we can do good quality care. So we're going to move people kind of in that direction. We also, in order to help the doctors and the hospitals and others to be able to cut their costs, we do several other things. We reform the medical malpractice system. Right now, if you get injured by the doctor or the hospital, well, if it's not a big injury, first of all, they don't want to talk to you about it. You can't find out if it's serious, and if it's not going to be worth enough to go to court, you have a hard time getting anybody to take your case. Only the more extreme cases ultimately go to court, and many of them actually get settled beforehand, and there's usually a confidentiality agreement. So we don't learn from those mistakes well enough. And so what we've done is a system that has worked quite well